Patient Psychiatry at the University Health System in San Antonio. He is also the director of a controlled access unit and general medicine unit. He's also a member of the Patient Experience Leadership Branding Team that's elevated strategic initiatives to ensure all patients receive excellent care. Prior to joining UHS, he worked as a director for health promotion and wellness at Community First Health Plan. He actually began his career at Claryville Child Guidance Center and Behavioral Health Hospital for Children. Currently, he is certified in project management, as a nurse executive, in healthcare quality, also as a patient experience professional. And in 2021, he was recognized as the best 25 nurses in South Central Texas. Paul?
Hello, my name is Paul Buckle. I am the Psychiatric Nursing Director at University Health in San Antonio. We talked about self-awareness yesterday at the pre-conference, so I wanted to let you all know this is my first time presenting at a nursing conference, and I am quite nervous. I did take a prescribed medication about an hour ago. And I can tell you it's not working very well. And I'll have to talk to my therapist about this on Monday. So my colleague, Dr. Manalili, she told me that if I was nervous to look up or look down at the top of people's heads and I would feel better. But that was before we had seen this auditorium. Considering that you all are above me, that was terrible advice. But I'll try and look at your chins and see if that helps. So how does one become a psychiatric nursing director? Well, I want to tell you a little story. When I was a kid growing up in Houston, my mom would send me to school wearing black and yellow Pittsburgh Pirates and Pittsburgh Steelers jerseys. One day my teacher asked me, "Paul, are you from Pennsylvania?" And I proudly told her, "No, but my parents are in a gang called the Latin Kings." I won't tell you if that was true or not. But after that, I became lifelong friends with my Child Protective Services social worker. So, one way to tell if I have gained a patient's trust, especially on a psychiatry unit, is if I can make them laugh. Laughter can really be the best medicine. So this is a quote that I really like. It says, "Mental pain is less traumatic than physical pain, but it is more common and also more hard to bear. The frequent attempts to conceal mental pain increases the burden. It is easier to say my tooth is aching than to say my heart is broken. But for some, by heroism, overcome even chronic mental pain. They often produce brilliant work and strengthen and harden and sharpen their characters till they become like tempered steel." Imagine being someone who is living with a diagnosis of bipolar or schizophrenia. You're doing well, you take your meds every day, you attend therapy, you have a good job. And then one day you're in a serious car accident and you end up in the hospital. What does that do to someone with a mental health diagnosis? What does that do to someone without a mental health diagnosis? So as we said, I'm from University Health in San Antonio, Texas. University Hospital has a designated 20-bed inpatient psychiatry unit. On the same floor, across the hall, there's also an adjoining 9-bed general medicine unit. The inpatient psychiatry medical director and the psychiatry consult service are both housed on the same floor right outside those units. So based on the premise that concurrent and coordinated medical and psychiatric care is more efficient and provides better outcomes for this patient population, we propose that the adjoining 9-bed unit be converted to an integrated medicine unit. The unit would treat patients with requiring primary medical acute care and also have co-occurring psychiatric illness. So a little more background on this is that the idea for the integrated unit really came about due to COVID. Some psychiatric patients were coming to the hospital and very sick with COVID, and they were being admitted to the medical surgical units. And many of the nurses were not familiar with how to care for these patients. Myself or my nurse supervisors, we would go to the other units to try to assist as much as we could, but it was clear that the nurses needed more help. So the why for nursing. This was mentioned, I think, in the Prescaney talk earlier, but there's a lot of workplace violence going on. Risk of violence, particularly, is 3 times greater for men with schizophrenia and 4 times greater for women with schizophrenia compared to the general population. One study that I read said that nurses in a major population-based study showed a rate of physical assaults at 13.2 per 100 nurses and a rate of 38.8 per 100 nurses per year for nonviolent physical events. And workplace violence is strongly associated with negative psychological outcomes, including post-traumatic stress disorder, depression, anxiety, sleep, and fatigue. So we looked at a study from the University of Iowa, which compared the treatment of patients with comorbid medical and psychiatric illness admitted to a high acuity integrated medicine unit versus a traditional general medicine unit. Medical symptom improvement was comparable in the 2 units, whereas psychiatric symptoms improved more on the integrated medicine unit than on the general medicine unit, despite more significant illness and comparable lengths of stay. Collaborative care on the integrated medicine unit allowed for shorter total lengths of stay for medical patients with serious psychiatric illness than would have occurred had the traditional approach to care been used. And the integrated medicine psychiatry treatment unit represents an efficient and effective process improvement in the way that medical patients with comorbid medical and psychiatric illness can be treated. So the integrated medicine unit program was administered through the Department of Internal Medicine, which ensured that a primary care physician with expertise is on par with medical services in the rest of the hospital. And then the IMU program was supported by the Department of Psychiatry, which ensured that a psychiatric physician coverage was available 24 hours a day. Patients could only be admitted to the unit if they had an active medical or psychiatric illness. And all nurses that were hired to work in this service area, they did so because they wished to combine medical and psychiatric nursing skills. Each received training in medical and psychiatric nursing techniques with more time devoted to the clinical discipline from which they had not come. And the charts were reviewed 24 hours after admission and every 3 days until discharge. So the results. So at the time the study was done, they were using the Global Assessment of Functioning. And the Global Assessment of Functioning is a scoring system that mental health professionals use to assess how well an individual is functioning in their daily lives. And the scale was used to measure the impact of psychiatric illness on a person's life and daily functional skills and abilities. Scores range from 0 to 100, with 100 representing superior functioning and 0 representing very poor functioning. And as you can see, on the integrated medicine unit, the patients had a lower GAF score upon being admitted, but they showed greater improvement by the time they were ready to leave. So some implications. Whether patients with both medical and psychiatric illness were treated on the general medicine unit or on the integrated medicine unit, they required longer hospital stays than patients without psychiatric comorbidity. With a traditional approach to medical care, the patients with medical and psychiatric illness would require up to 21 days of hospitalization, compared to only 13 days on the integrated medicine unit. This reduced length of stay of up to 8 days could save the hospital $1.4 million per year. That's based on $500 per day, 350 admissions in a year. The competency of the nursing staff is necessary for a medical psychiatric unit to be able to function. The physical care provided to the nursing staff can at the same time be seen as psychotherapeutic contact. So some of the recommendations and some of the things that we have done at my hospital currently. We created an inclusion criteria for a 9-bed integrated medicine unit to include patients with primary medical illness and a comorbid psychiatric diagnosis, demonstrating self-harm, psychosis, mania during the course of an acute medical illness, which makes it difficult to administer care in a non-IMU unit. All the nursing staff are trained in verbal crisis de-escalation, trauma-informed care, caring for patients with intellectual and developmental disabilities. Medical nursing staff will be cross-trained for 4 weeks in the inpatient psychiatry unit. And this is the number one most important thing that we have done so far. We were kind of building the plane while we flew it. When we started this unit, we didn't shut the unit down and start from scratch. We were a general medicine unit. We slowly changed over to this integrated medicine unit. And as we began cross-training the nurses in the psychiatry unit, there was a noticeable difference in the care that was provided And especially our medical director for psychiatry noticed a big change. That was very, very important to the success of this unit. We also created an acuity-based staffing model that takes into account patients' medical and psychiatric needs. I can also say that the staffing ratios for this unit are much smaller than other units, so we have a ratio of 3 to 1. And so originally it started out each nurse took 3 patients, but over time the nurses wanted to change that. So what ended up happening is 2 nurses would take 4 patients each, and the charge nurse would take 1 patient, so that they would be free to help the other 2 nurses when crisis arose. So one important thing for us is that the nurse is always leading if there's a crisis situation, the nurse is always the one leading, no matter who's there, whether it's the police department, the psychiatrist, the social worker, because those nurses know the patient the best, likely to have the most trust with the patient. So while that one nurse is doing that, the other nurse is calling the doctor, getting medications if needed, things like that. It's worked out really well. We also have a poster out by one of my colleagues, John, who's here as well. We developed a behavioral health emergency response team that includes nursing staff, nursing supervisors, psychiatrists, a peace officer, a social worker, and chaplain that can be called all to come whenever there's a crisis situation that occurs. Another lesson learned for us was that there was an increased number of patients on one-to-one due to suicidal ideation and other issues on our unit. We currently average about 4 patients on one-to-one per shift. So after our first year of making this change to an integrated medicine unit, we were approved for 4 additional FTEs to help cover those patients that are on one-to-one. And the other thing that I will say is that the importance of communication between nurses, between disciplines is very important. We often have to work with our legal department, our ethics department. Many of our patients are at the hospital on emergency detention or other things, and so they might lack capacity to leave AMA, and of course that creates lots of difficult situations for the patients and their families, a lot of tough discussions. So this is definitely the most challenging thing I have ever done so far in my nursing career. I am 100% certain that our nurses feel the same way. And in my mind, these nurses really are heroes. So I just wanted to close with a quote. It says, "A hero is one who heals their own wounds and then shows others how to do the same." And that's it. Thank you.